Hi, my name is Omar Nadeem. I'm from the Dana-Farber Cancer Institute. This is an exciting year for patients that have precursor myeloma. So as you all probably know, there's patients that we get identified that have the monoclonal proteins but don't yet have the damage associated with myeloma. And this entity called smoldering myeloma is patients that have more than 10% abnormal plasma cells in the marrow. It's a pretty heterogeneous population where some patients will develop myeloma, some patients won't, and we now have some tools that we can use in the clinic to identify patients that are at high risk for progression in the next 2 years. And there have been numerous trials looking at early intervention in these patients to see if we can actually prevent the damage, organ damage that occurs from multiple myeloma. So at this meeting, at the ASH meeting, we'll see the phase 3 results of the Aquila trial, which is showing benefit of single-agent Daratumumab versus observation in patients with high-risk smoldering myeloma. And this trial improved progression-free survival for these patients, and there's a trend towards actually improvement in overall survival. And that's the first time we've seen that in a while, where you actually, treat patients before they develop the disease and perhaps impact their outcomes to that level. But with single-agent Daratumumab, the response rate is about 60%. So, about almost 1/3 of patients don't respond to that agent, and then patients still do progress. So at that 5-year mark, about 40% of patients still develop myeloma. So how can we do better has been an area that we've been trying to understand and answer via some of the clinical trials. So we have some updates at this meeting looking at slightly different strategies for patients with high-risk smoldering myeloma. We have a trial, first of its kind, looking at CAR T-cell therapy in these patients. So patients that are at high risk of developing myeloma can be enrolled into that trial, and we'll be sharing results from our safety run-in, which is the first 6 patients treated with Cilta-cel, which is an anti-BCMA CAR T-cell therapy product that is approved for patients with relapsed refractory myeloma, and treating patients with no induction therapy where they go right into CAR T-cell therapy. We limited the amount of plasmacytosis patients should have at the time of enrollment to 40%, and the intent has been to really reduce the toxicities as much as possible. We also started with 2 different doses as part of the safety run, and one is a slightly lower dose at the 0.5 dose, because the standard dose is the 0.75 times 10 to the 6 per kilogram CAR T cells, right? So we kind of started with the first 3 patients, the lower dose, escalated to the next 3 patients when we did not see any dose-limiting toxicities, and all 6 patients went through without having any dose-limiting toxicities with the CAR T-cell therapy. We did see some of the expected toxicities with these agents. So because of the lymphodepletion that is necessary prior to CAR T-cell therapy, you do see some incidence of neutropenia, but thankfully we didn't see any evidence of or any cases of febrile neutropenia. All patients did develop cytokine release syndrome as expected with these T-cell therapies, but nobody developed grade 3 or greater cytokine release syndrome. We had to give tocilizumab and dexamethasone to a handful of patients, but all of that was very manageable, and there weren't any issues for high-grade CRS, so far on this trial. There was one case of a Bell's palsy. One patient experienced that, which is again a known issue with some of these CAR T-cell therapy, but that was very transient, resolved actually on its own within 2 weeks. Overall, the safety profile for these first 6 patients looked quite good. And the great news is that these patients, all of them responded. Not only did they respond, they all have complete responses and all have MRD negative responses at 10 to the minus 6. And the first 3 patients we now have beyond the 1-year mark, so they have sustained MRD negativity with this one-time therapy a year later, and the rest of the patients still remain with MRD negative disease at the time of their last follow-up, and nobody has developed any progression to overt myeloma to date. So, this is the first of its kind trial looking at this type of approach in these precursor patients where they have a much fitter immune system, and our hope is that this one-and-done treatment can prevent myeloma in their lifetime, but we need to see obviously longer follow-up, and the study is enrolling in the expansion cohort at this time. Slightly different study, again, looking at different approaches in this population. As I mentioned, Daratumumab as a single agent has shown benefit versus observation, but what about combining Daratumumab with the agents that we do for patients with newly diagnosed myeloma? We typically will give Daratumumab, Revlimid, Velcade, Dexamethasone, the most commonly used frontline regimen for newly diagnosed myeloma. And we've been doing a trial looking at that Dara RVD regimen in patients with high-risk smoldering myeloma. And we have modified the schedule to make it more tolerable, so the doses are a bit less, the schedule is a bit less intense. And this is a 2-year treatment program driven by MRD. So patients that achieve MRD negativity at that 2-year mark will come off, and those that are still positive will be randomized to either 2 more years of Daratumumab and Lenalidomide, or will go on observation. So we've been giving updates of this study over the years. We've now enrolled 45 patients to this trial as part of this last data cutoff. Majority of these patients met high-risk criteria per the either 20-20 model or had other high-risk features that have been established. And the overall response rate is 98%, and over 60% of patients are in a complete response. And at the patients that have gone through the 2-year mark, again, not everybody out of those 45, but those that have, about 65% of those are MRD negative at 10 to the minus 5 to date. So, and we're seeing those numbers get better and better over time. And our hope is that this will again lead to long-term remissions for these patients, so they don't have to worry about development of disease. So there are two slightly different approaches. One is looking at immunotherapy. One is looking at more traditional combination therapy that we use for myeloma. And we're trying to see if we can really prevent disease and symptomatic progression in these patients with these interventions.